Hello, hello. You're welcome to another presentation. Today we are talking about two cardiac rhythm beats that every medic, PA, doctor, nurse, you're going to see this in your clinical practice. If you're medical students, welcome. This is something that you ought to familiarize yourself with, and I'm sure that it's been taught extensively in medical schools. This is not one of the topics they don't teach. They actually teach it, maybe not so much, but they do give it attention because they know that this is a very common. So depending on where you're schooling from all around the world, you might already have known or heard about atrial fibrillation and atrial flutter. Now, when you're in ED on the wards or you're reading ECGs at 2 a.m.s, atrial flutters and atrial fibrillation, they show up everywhere. So let's demystify them. Let's make them stick. Let's make you confident. So what is atrial fibrillation? We usually say AF. Today we are talking about AF because it's the commonest arrhythmia that you will find in your practice. And so in AF, the orchestra, it's lost its conductor. There's no one conducting the music. So instead of synchronized P waves, what we get is chaotic electrical signals. The atria, they quiver, that is, they fibrillate, and as a result, the ventricles respond irregularly and often rapidly. So AF is, if untreated, is a ticking time bomb for a stroke because when the heart begins to beat irregularly out of sync without anything conducting the music, then clots begin to form. Now, in a normal heartbeat starts with an electrical signal from the sinoatrial node, and as you can see here, here is your sinoatrial node. It is found where? In the right atrium, right? And this is where electrical impulses are automatically generated. This is where they start from. This is where they are created. So the signal passes through the heart chambers, right? It goes across here. And what do we have here? We have the atrioventricular node. If there's a block here, what happens? Or if there's a disease with the sinoatrial node, the atrioventricular node takes over. It won't take over as well as the sinoatrial. It won't do the good job that sinoatrial node does, but it can, you know, it can generate about 40 to 60 impulses, if the sinoatrial node does mess up. And so what happens here is that um yes, as I was saying, what happens here is that if there's a block here, so from the atrioventricular node, if the atrioventricular node, and if you've heard my other lectures, you know that I consider the sinoatrial node, maybe the consultant, the atrioventricular node, the registrar. If the registrar refuses to come to work or is sick for whatever reason, what happens, right? This is but just for clarity, the impulses are transmitted via the atrioventricular through the bundles. You have the right bundles, right? And we have the left bundles. But the left bundles, and when their impulses cannot be, that's where you have a right bundle branch block. Let's say the walls of the right ventricle are too thick. And the impulses are delayed in conduction. You could have a right bundle branch block, or if there's a block basically stopping those right branches. Also could happen on the left where you have your left bundle branch block, and that's where you talk about, oh, is this a left ventricular hypertrophy or is this myocardial ischemia? Because what happens if the walls of the left ventricle, if there's no blood supply to the left ventricle, you have a left bundle branch block, right? But here we have the Purkinje fibers. The ones that are transmitted at this end are Purkinje fibers. And in this Purkinje fibers, if for example the reg does not come to work, the Purkinje fibers are like the SHOs or the house officers. They take over the work, right? And they may generate beats at about 20 beats per minute. But yeah, they will do what they have to do within the circumstances. They will still get work done. But basically, you need to just understand how electrical signals are conducted. Now, in irregular electrical signals, what you have here is the signals conducting from here. They're not coming from the sinoatrial node. You can see the sinoatrial node is on its own, or you could see the reentrance mechanism is either they're going round or round. they're going round and round the reentrant mechanisms because there's no circuit, to pass through. Maybe there's a disease or there's a blockade. So they're going round and round. Some may pass through the atrioventricular node. Some may pass through the left ventral branch, right bundle branch block. Some may go from the right atrium to the left atrium, go round and round. If they are lucky, there's an open block, they come back. But if it's a closed loop system, you just have the heart beating out of sync, don't you? So now we are going to discuss what is atrial flutter. Atrial flutter is a more disciplined cousin of the atrial fibrillation. And it's still fast, but in a more regular fashion. That's why we say regularly irregular heartbeat would be atrial flutter, but irregular heartbeat would be atrial fibrillation. So it is a macro reentrant loop, usually around the right atrium. The atria fire around 300 beats per minute in a tight loop, and the atrioventricular node opens every second beat, creating a ventricular rate of 150 beats per minute. So here you have like a sawtooth pattern. And don't miss this is an ECG. The sawtooth pattern is a giveaway, it's pathognomonic. But just think again, if you've listened to my other lectures, some of the other lectures I've made in other videos, I talk about a roundabout system. So imagine that the impulses are being conducted in a roundabout junction like a car, and all the exits of the roundabout are closed, but every two beats, for every two times that the car goes round the junction looking for an exit but not able to find one, there's an exit. It lets the car out. But when another car comes, it lets it cycle the roundabout two times before it lets the car out another time. So that's what happens here. And how do you classify atrial fibrillation? This is very important. You could have your paroxysmal, you could have your persistent, and you could have permanent. Now, paroxysmal is simply atrial fibrillation that comes and goes in under 7 days. So a patient comes to meet you and says, "Oh, um I've had this irregular heartbeat." Or maybe they say, "I've had this irregular heartbeat. My watch picked it up as atrial fibrillation, and now it's gone. It's gone. I noticed it yesterday, but today it's gone." And maybe within a week, they do not have any other atrial. That's a paroxysmal atrial fibrillation. Persistent is lasting more than 7 days or needing cardioversion, right? Permanent is we are no longer trying to restore the sinus rhythm. We've just given up. We know it's there. It's documented. You look at the notes from a year ago, 2 years ago, they've always had it. What we're just doing is we're managing what we can in terms of hemodynamic stability, rates when we can, but we're not really worried anymore. Then we have the asymptomatic versus the symptomatic, right? In asymptomatic is sneaky but dangerous. So they don't have any symptoms. You do an ECG for something else, or and then you find it is often discovered after a stroke. So we have to screen carefully, right? Now, in classifying it, atrial flutter, we talk about typical and atypical. Now, we've talked about a reentry circuit, usually around the tricuspid valve, especially the isthmus, and there are two flavors. It's either the anti-clockwise. The anti-clockwise is the classic type, and that's where you have your sawtooth pattern in 2, 3, and AVF. But in clockwise, it's less common, and you have a reverse pattern, right? And for your atypical flutter, it means that the circuit is elsewhere. It is less predictable and it is harder to ablate, basically. Now, like I was saying about the typical atrial flutter, it does not fulfill the criteria for the typical atrial flutter. It is associated with higher atrial rates, rhythm instability, and it's difficult to treat with ablation. Now, let's think of the causes of atrial fibrillation with a mnemonic pyrate. AF doesn't come out of nowhere, so you use this mnemonic. P is pulmonary causes like your PE, like your COPD. I is ischemia. R is rheumatic disease. A is alcohol. Have you heard of holiday heart syndrome, the alcohol holiday heart syndrome? So it could also be due to age, autonomic tone. T is thyroid in hyperthyroidism. In fact, one of the blood tests you do for discovered AF is you do a thyroid function test, right? It could also be due to elevated blood pressure. It could be to electrolyte imbalances. That's why you do your bloods again. It could be due to sepsis. It could be due to sleep apnea. It could be due to surgery. So remember the acronym PIRATES. Sleep apnea is massively underdiagnosed, but leads to more than, well, let's just say approximately 40% of cases. So screen aggressively when they are telling you they have atrial fibrillation. Screen for sleep apnea or, vice versa as well. Now, signs and symptoms of atrial fibrillation. Atrial fibrillation is the master of disguise, right? Is the master of disguise. Some patients feel nothing, and others will feel like they're literally about to die. So, what you look out for is you look out for palpitations, look out for breathlessness, look out for lightheadedness, look out for confusion, anxiety, chest pain. So that's why one of the things you do when a patient comes and says, "Oh, I'm having a panic attack." Oh, of course, the first thing, well, you we do a lot of things simultaneously anyways, but arguably one of the first things you do is an ECG, right? And of course, you do your bloods, your vitals, you do other bits. But an ECG is extremely important, as you would guess. So always feel the pulse yourself. If it is irregular, then you think AF. Now, the risk factors are valvular heart disease. So when a patient does have AF, in my trust where I work, one of the things you do to investigate it quite compulsory is your echocardiogram because you're trying to rule out a valvular problem or a structural heart problem. AF loves the elderly, but you can flirt with anyone who has a valvular heart disease, who has ischemia, who has a cardiomyopathy, who has diabetes, or who is obese. Now, the complications. One of the major complications of AF is a stroke, and that's why we talk about the CHADVAS score, because the CHADVAS score guides us on who needs anticoagulation and who does not. You use the CHADVAS score along with your orbit score. We no longer use the AS-BLED score. The AS-BLED score is now phased out. What we use is the orbit score. And what are we doing? The orbit score tells you how the likelihood of a person bleeding, you know, bleeding over bleeding or the high risk bleeding that can occur from using anticoagulation, and you use it to gauge the risk against the CHADVAS score. So this person needs anticoagulation, but they have a very high orbit score. Well, you want to weigh the risks and benefits, engage in some shared decision making, and determine whether you need to prescribe a blood thinner because you know that the one of the major complications of having atrial fibrillation is a stroke, and a stroke risk is 5 times higher in atrial fibrillation, and that's why anticoagulation is often not optional, right? It can also cause heart failure because you have fast irregular heart rate. That weakens the ventricles. They're not efficient at pumping blood anymore, and you could have stasis, you could have heart failure. Now, start with your hands, start with your pulse check, right? Then your hairs, you auscultate. The golden test is an ECG, and what will you find on an ECG? You will have no P waves, right? No P waves. You will have fibrillatory waves, right? And you could have irregular RR intervals. So one thing I look out for in AF is absence of P waves, chaotic waves. Then you're looking at atrial fibrillation. Now, an ECG is your best friend, right? For atrial flutter, right? Now, in this is a normal ECG anyways, but in atrial flutter and atrial fibrillation ECG, and what you can see here is look at this, the distance between here and the distance between here and the distance between here and here, right? What you're looking at, what you're looking out for first, there's no P wave. You're looking for irregular heartbeats. So this will differ to here, this will differ from that, and this will still differ. There's no clear pattern many times. In fact, there is no clear pattern, and that is the pathognomonic feature. You have maybe 2 hour intervals here, three boxes between this next hour, four, 1.5, 2.3 boxes, and that's what you will find. Now, in atrial flutter, right? In atrial flutter, what you have is an irregularly, so the distance here is a sawtooth pattern, right? So there's actually a pattern to it, but in atrial fibrillation, there is no pattern to it. And in ECG, in case of atrial flutter, is you have regular atrial activity, right? It could be 300 beats per minute. Then you have your flutter waves, right? And then your flutter waves, it is classic sawtooth pattern in 2-3 AVF. So the trick is turn the ECG upside down and it's easier to spot the teeth. Now let's do a little bit of case-based learning, right? In this ECG, what strikes you, right? So in this ECG, I think this picture, I'm trying to see if I can edit this picture. But what you have, right, is an inverted flutter wave. If you look at 2, 3, and AVF, it's an inverted flutter waves, right? There are upright flutter waves in V1, but basically, how do we know this is a flutter wave? Because this is classic anti-clockwise flutter, right? This is classic anti-clockwise flutter. Even though there is no clear P wave, of course, you see something that looks like a P wave in between. What you'll find is there is a pattern to the madness. Now, this is not your classic atrial flutter that you'll find, but I purposely brought up this example for you to understand that there's some kind of arrhythmia going on here. But because there's a pattern to the arrhythmia, it still looks quite regular, right? And you're making out a bit of what looks like a P wave, right? You're making out and this will help you when you're trying to differentiate things like an SVT from an atrial flutter. You're making what looks like, but there is a pattern to the madness, right? And note the occasional irregularity. Now for here, there's an atrial flutter with a 2-to-1 block. And for me, what that means is that for every second, there are no visible P waves. There's a sawtooth baseline in V1 with flutter waves visible at 300 beats per minute. And you have here that the T waves look concealed. The heart rate of 150 beats per minute with and with no visible P waves makes this flutter like a 2-to-1 block. So at every second loop, it opens up to form a ventricular rate. So that's why we call this 2-to-1 because you have one, and then you have a second one that conducts to form a ventricular rate. If AF is episodic, if it is paroxysmal, right? A single ECG unit a single ECG might miss it. So they might tell you, well, I had it, now I don't have it. I have it, I don't have it. And they come to you and as at the point you are doing the ECG is normal sinus rhythm. It doesn't mean the patient is lying. It's just probably the fact that you're not picking it. So they can say, well, if I've had it, I have it every 2 days. Then you could do a 24 to 48 hour Holter monitor, and the patient can give symptom diaries. It picks up rare brief AF episodes, and it is used for patients with intermittent palpitations or embolic strokes of unknown origin. So you don't need to stay in the hospital. You can carry on with your daily activities, as you can see in the Holter monitor. Now, the stress test is useful if you suspect ischemic heart disease. Now, there are some kinds of ST changes or findings where a stress test is prohibited. You don't do stress testing in Takotsubo. You don't do stress testing. You should know. But a stress test is useful if you suspect ischemic heart disease with underlying atrial fibrillation to provoke rate-related symptoms. It's not first line in diagnosing AF, but it's just important to know because it might be the last resort. Then a transesophageal, you could have an event recorder again as well, like we've mentioned. A transesophageal echocardiography is gold standard for precardioversion in AF greater than 48 hours. So if you want to cardiovert in AF that's greater than 48 hours, then you do need to have the transesophageal scan, right? You must, because this is important because you must rule out an atrial thrombus, and this is where it shines. It visualizes clot hiding in the atrial appendage. Now, of course, you have other tests that you could do, like a chest X-ray to rule out heart failure or pulmonary disease. You need to do your TSH, your thyroid function test to check electrolytes, look out for infections, anemia, because atrial fibrillation is a consequence. So you must not forget to find the cause. Now, I've talked about the Chadva's score. I've talked about the Hobbit score, but know that your DOACs are first line with current guidelines. You use warfarin when they have mechanical heart valves or where they're refractory to DOACs, where the clot formation as refractory trial where drugs are contraindicated, and you use heparins in acute settings, right? We no longer use Asbled in my trust. Some people still use Asbled, but we talk about Orbit. Now, weight control is default for most stable patients, and that's where you're talking about your metoprolol, your bisoprolol, and you can also use your non-dihydropyridine calcium channel blockers like your verapamil, right, and your diltiazem, and you can use digoxin in sedentary or elderly patients, and you're targeting a resting heart rate of less than 100 beats per minute. So once you let the rhythm go, you let the rhythm go, and what you just do is just you slow down the chaos. For rhythm control, what you're looking at is how do I restore the sinus rhythm? And you're doing this for younger patients, highly symptomatic patients, first episodes, heart failure caused by AF, right? So, electrocardioversion is the fastest method. Pharmacological agents like amiodarone, flecainide, propafenone can be used. You rule out shock anyways before you rule out clots before you shock. Now, in catheter ablation, if drugs and shocks fail or a patient relapses constantly, then ablation is the next step. It burns out the rogue circuits. It's especially effective in atrial flutter. And in atrial fibrillation, it's best for paroxysmal or symptomatic patients. Sometimes every atrioventricular node is ablated and the pacemaker is inserted if no rhythm control